doing digital stories in the past. And a lot of people that were able to coach people through the process. Yeah. I know, yeah, and I talked about, it. We're supposed to be doing a similar, it's called Share Your Story. For service ISLE. And we're kind of required to do it for some of our grants, so I'm planning to go through that training at some point, but the hard thing is we don't make our time now because. Behavioral health related, and I'm just still, that's the transition. But at some point I'll get final kind of training, but so I don't know how similar it is. It's the same kind of.
I'm sure Regardless gonna be great. Whatever you, however you want to be put it on.
Not with you, but I need a good one on speaker. Eventually, I'm gonna go to a schedule where I'll get everything.
You wanna go next?
Friday, Friday, project day.
Are you, do you wanna do a picture, Marguerite? He's just taking them real quick. Go, Kelly, go. Where to the back wall there?
I just think their world was. Right behind.
Yeah, he's doing it.
Okay.
Okay.
My hair look okay?
Oh, look at this. I know. It's like.
There, have you go around against the brick wall.
It's just, it's clear. Awesome. Let's go, yeah.
I have to do a favor. Active information.
For me?
For you.
Yeah, my client.
Okay, that'd be great.
You go ahead.
It's all right, he's here.
Okay, I'm glad it started out also.
Absolutely, I'll do my,
Thank you so much.
Thank you.
Like my photo dress.
Go Vernon, you're after Bob. Raphael, you're after Vernon.
Are we trying to get a photo?
No.
It's too much to ask.
No.
Oh, I was on the movie.
Yeah.
So.
hello, Marguerite.
Hello, how are you, Robert?
Good, how are you?
Good. To get to do some things in the.
How's it going, Vernon?
All right, people.
Oh, okay.
Look over by.
Yes.
It's very much field work, so. I'm just thinking.
Oh,
yeah. To make it. Following a lot.
I'll give you look all official. Clean your badge.
I already. But yeah.
All right.
I'm terrible at checking my personal emails, so it's great. Great.
Okay, we are about to start this meeting. Did you both? Did you get your photo taken? Thank you very much. Call this meeting to order at 12:17. Welcome to the monthly Behavioral Health Board meeting. We are the advisory board for the Board of Supervisors. We hold this meeting on the fourth Thursday of each month and it runs from 12:15 to 2:15. We meet in person at 507 F Street in Eureka. This is a public meeting and everyone is invited to attend. Members of the public may participate remotely. The minutes and the agenda can be found by searching online Humboldt County Behavioral Health Board. We provide time for public comments early on in the agenda. Public comments need to be limited to 3 minutes and pertain to matters related to behavioral health. We ask that you make your comment in a respectful manner. Please note this meeting is being recorded. And if you have any questions, contact myself, Laura Montagna, or any of the Behavioral Health Board members. And with that, Joe, if you will, do the roll call.
Sean Berger. Here. Marguerite Story Baker.
Here.
Bob Doherty.
Here.
Raphael DeCamp.
Here.
Laura Montana.
Here.
Natalie Arroyo.
Here.
Kelly Johnson.
Here.
Jeanette Keller. Bernie Price.
Present.
Stephen.
Alex Chandler,
Here.
we have four.
We have a quorum. Very good. Thank you all. We will go around and introduce staff, starting in this room with.
Sorry, for the deputy director.
So, Deputy Director.
Go ahead and just introduce.
Saul Lopez, District Finance Site Director.
Laurel, do you want to introduce yourself?
So sorry.
You're fine.
Laurel Johnson, Department of Health and Human Services. I'm an analyst in DHS at it. And you know,
Joe McManus, Executive Secretary.
Connie Beck, Health and Human Services Director. All right, and we'll go to online, just popcorn to the few of you.
Hi, Sharon Wolf, DHHS Legislative Analyst. Very nice to be with you, and I will popcorn over to Sonia.
Hi, everyone. Sonia Levy-Floyd, Chief of Pronouns. I'm a Senior Program Manager now at Children's Behavioral Health, representing several different programs in children's, but also still supporting and supervising the Humboldt County Transition Youth Collaboration. And I will pass to Kelsey.
Hello, everyone. Kelsey Reedy, they, them pronouns, youth organizer with the Humboldt County Transition Age Youth Collaboration. All the folks online. Oh, let's go to Genevieve.
Hello, I'm Jenny Stubblefield. I'm interning for Natalie Arroyo.
Hi. Melissa.
Hello, is this working? Hi, everyone. I am Melissa Nelson, Patient Navigator here at Aegis.
Awesome. All right, I think that's everyone. Are there any adjustments to the agenda? Seeing, hearing none, we will move on to public comments. Are there any public comments? And moving on then to action items. We need to approve the minutes from 5/22/25.
So moved.
All right, all in favor of approving the minutes? Say aye.
Aye.
Opposed? Bam, minutes approved. Wow, look how fast we got to you, Jack.
Awesome.
And now the presentation we've all been waiting for from Jack Brazil.
Yeah, so I am going to present today on our adult system of care. This is our adult outpatient programs that we have here with County Behavioral Health. I'm gonna run through those programs, and I'm gonna do it in kind of using what we call a vignette, right, or an example, so we can kind of see how it might look for somebody entering our system. Okay. Here we go. Is it this button? Yeah. What's this?
Okay.
Okay, so first thing we'll do is just kind of go through the programs that we're gonna look at today. Same day service, the access program, the outpatient, Hope Center, arrest program. Our CCT program, our regional program, and then older adults. I'll go through those acronyms as we. All right, next slide. All right, so the first thing we're gonna do is meet Sam. Sam is a 22-year-old male who is experiencing elevated mood, difficulty sleeping, impulsive behaviors, and irritability. Parents are worried for him as he has not slept in 3 days and is becoming increasingly agitated when they try to engage with him on a solution. So Sam's parents then take him to same day service. Next slide. So they take him to 720 Wood Street, where he was able to meet with a clinician in the same-day service program within an hour. The clinician performs a crisis risk assessment to determine if Sam needs to go to a psychiatric facility. At this time, Sam was not vocalizing any safety issues, but did admit he was scared that he could not go to sleep. He admitted to past episodes of depression where he struggles to get out of bed and is mostly worried that he will become depressed again. The clinician was able to work with the client on some coping skills and provide resources for education on the symptoms of bipolar. Sam was willing to sign an ROI for his parents, and together with the clinician, they developed a safety and aftercare plan. The clinician was able to get him set up with an appointment with the Access program to initiate ongoing mental health treatment. Next slide. So here we see Sam at the same-day service, getting evaluation by a clinician. At same-day services, we do risk assessments and 5150 evaluations. We screen for the necessity of ongoing services, and we offer some brief therapy and some case management. Next slide. All right, here we are in Access. So Sam came in at his scheduled time and met with a mental health clinician for his adult assessment. This is a Medi-Cal required assessment that allows us to determine treatment needs and ensure Sam is meeting medical necessity for county services. Sam was given a diagnosis of bipolar, and based on his difficulty in his relationship with the parents, that puts his housing in jeopardy, Sam does indeed meet criteria for county behavioral health services. Sam is given an appointment with a psychiatrist for the following week and encouraged to come back to Access if his condition persists or worsens. So at Access is where we do our behavioral health assessment. We determine the eligibility for services. We do some treatment planning and get follow-up appointments and some brief therapy and case management. So in Access, this is where we would really determine, this criteria as I mentioned, medical necessity, right? And a lot of people are kind of familiar with that in the sense that sometimes folks will come into county and then refer them back to partnership or to services in the community as opposed to getting services in-house. And medical necessity is really based upon severity, what we said, functional impairments, right? So where in your relationships, occupation, housing, your ability to access food, clothing, shelter. So those things would need to be impaired in addition to the need for that mental health diagnosis. All right, next slide. All right, so in addition to psychiatry, Sam is now getting adult outpatient services. He's referred for therapy and some case management with the adult outpatient program. Sam identifies the goal of wanting to get his own housing and move out from his parents' home. His case manager works to link him to available housing resources in Humboldt County. His case manager also finds him a primary care physician and ensures he makes his appointments to his psychiatrist and any other necessary medical appointments. His therapist has identified some past trauma with Sam that causes him to stress at times. They work together to develop strategies to move through these traumatic experiences to where they no longer impact his mood and function. Over the course of time, Sam's case manager was able to work to get him into a local supported housing unit, downtown Eureka. Sam is thrilled and reports feeling genuinely happy for the first time in many years. So I know it's kind of in the purple there, but so an adult outpatient, we do individual therapy, case management, group therapy, and then individual rehab. Individual rehab is done by some of our paraprofessionals, our case managers, and it's really kind of focusing on specific symptoms. Just like, hey, let's work on your sadness today, or let's work on hopelessness, or let's work on our anger management skills, right? So rehab is very specific to a particular mental health symptom. Okay, next slide, please. The resident engagement and support team, REST. All right, given that Sam is new to housing, his case management is transferred to the resident engagement and support team, or REST. The REST program specializes in ensuring the success of recently housed individuals, especially those coming from homelessness. Sam meets with his case manager, who continues the good work from his his REST case manager, who continues the good work from his adult outpatient case manager. The REST case manager also ensures Sam is able to perform tasks of daily living and is knowledgeable in resources to get the new apartment furnishings and housing accessories needed for success. One of, real quick on that, just so, not all the time would we necessarily transfer somebody who's got a case manager to a REST case manager just because they're housed, but just for the purposes of this, PowerPoint and highlighting what the REST team does, but, REST is really part of our innovation funding that we got a few years back. And it follows a lot of housing first principles. And they do a lot of work in our supported housing units throughout Humboldt County. So the main ones here, Bayview and ABC here, Pine Hill, have one down at Rio Dell. So our race case managers work really closely with those facilities. After Sam is housed, he meets his neighbor and they become friends. And Sam and this neighbor asks if he's ever been to the peer-run Hope Center. Sam admits to some social anxiety, but with the encouragement of his neighbor and case manager, Sam decides to attend the Hope Center. Next slide. Sam is nervous and apprehensive. It's his first day at the Hope Center. Upon entering, he hears some groovy music being played that reminds him of his childhood. He peeks inside and sees a DJ playing music and people smiling and laughing, sipping coffee. Sam has come on Wednesday's music class for one of our outpatient case manager DJs while participants pick the music. Sam meets many new friends at the Hope Center and is introduced to all the peer support staff. Through the week, Sam participates in many other classes and activities such as meditation and mindfulness class and book club. He even joins the May's Mental Health Awareness Walk to the courthouse to bring awareness to the community that recovery is possible. Next slide. So there's Sam in his bright green shirt on the May's Mental Health Awareness Walk. As great as AI could do. So the Hope Center is peer-led. All staff have lived experience with mental health and our substance abuse, as well as other life challenges. Activities include recovery education classes, focused on wellness and recovery. Community building activities are also offered at the Hope Center. So I'm hopeful most folks are aware of the Hope Center, but that is, they're located at 720 in the campus there, modular. It is peer run. All of the folks that work there, all the staff that we have identify as those with lived experience, and they provide a number of different groups and classes and one-on-one opportunities, and really this chance to promote recovery through lived experience. And it's a pretty great place. We all really like it. So that is the Hope Center. Next slide. Dun, dun, dun. Sam reaches a period of his life of high functioning and good stability. Unfortunately, things in life do not stay static. Sam received a phone call one day from his parents that his family dog had passed away. Despite the high level of support from his case manager, therapist, Hope Center friends, and housing community, this news devastates Sam, and he soon forgets to take his medication and withdraws from social activities, including missing his psychiatry appointment. Sam ends up in Semper Virens for grave disability after being found wandering the streets of Eureka with no ability to communicate who he was or how he would access food and shelter. Next slide. Sam is stabilized by the wonderful and hardworking treatment team of Semper Virens. In anticipation of his discharge, he is linked with a comprehensive community treatment program, CCT. This program designates Sam as a full service partner and assigns him a case manager and a clinician. This case manager and clinician meet with him and coordinate daily check-ins and identify areas. He's also giving nursing support, which involves a nurse coming to fill his pill box for him once a week and discuss any issues with medications he may have. Sam is also introduced to a CCT peer support specialist who, like the peers at the Hope Center, provides hope for him in his recovery journey by talking about his own lived experience. Sam's CCT case manager ensures that he makes all of his appointments and has a whatever it takes approach to ensure stability and recovery. Sam continues to attend classes at the Hope Center and also attends a men's safety group with the adult outpatient program. So CCT is one of our programs that, really important in terms of our Behavioral Health Service Act funding, that we have what they call a full service partner program, FSP. And this is really, working with individuals with severe and persistent mental illness to help them, stay out of the hospital, stay out of jail, stay out of emergency rooms, stay out of placements. And so that's where we kind of have this moniker of, whatever it takes, right? So we'll do a lot of different things for folks that are FSPs, including, making sure that they have, we paid for like tuition for them before. We've done, paid for certain programs for them to go to, gotten them bicycles to get back and forth to appointments. Done a number of things to really help promote their recovery, and CCT, works very much as a team, very collaborative approach to, working with folks, clinician, case manager, nurse, and therapist. Again, the one thing I would say here, just as that sort of clinical understanding too, is, this is happening really quickly, and if Sam had a therapist and a case manager, again, we wouldn't necessarily, disrupt his treatment team because he stepped down from SV necessarily, but just for the purpose of illustrating this, sure, we see the different programs we have and how people enter them. A lot of times the folks from CCT are stepping down from Semper Virens. And that's where CCT would get in the purpose. All right, next slide. So Sam works with CCT for over a year with great success. He has been the most stable he has ever been and feeling positive about his future. His parents made a move to Willow Creek, and Sam decided he wanted to be closer to them. His CCT case manager works with him to find housing in the area. Sam's care is then transferred to regional services. He is introduced to a new case manager that travels out to Willow Creek every week. He also meets in person with his new clinician and gets his psychiatry services through telehealth. Both his therapy and his psychiatry happen in a local office in Willow Creek right now. And Sam also got a new puppy at his home to keep him company.
It's a cute AI company.
That is a beautiful AI puppy. Okay, next slide. So just list here some regional services. So services offered to consumers in outlying communities. So it's basically kind of adult outpatient here in Eureka, but we go out to the places, Willow Creek, Garberville, Fortuna, Kimberville, and Rio. And we offer all of those wonderful things and SUD services. So one of the things we have in that program that we don't in CCT or in our other programs, a substance use counselor that goes along and substance use treatment, one-on-one. And then they do some groups sometimes if they get enough folks together. So we have those SUD, and we collaborate with our local community out there pretty well. And Kelly probably knows she did most of that groundwork for the collaboration. So, okay, next slide. Older adults. All right. So fast forward. Here is July 1st, 2065. Former Deputy Director of Behavioral Health, Jack Brazil, is now an elected member of the Board of Supervisors and Rich Beyond Measure. That seems exciting.
Slap Natalie. Oh, I love it.
Sam is now 62 years old. He has lived a good life in Little Creek, helping foster abandoned dogs along with his partner. At one point, some years ago, Sam was transferred from behavioral health to primary care for his ongoing medication needs, no longer requiring the specialized services of behavioral health. Eventually, Sam suffers from numerous health problems requiring travel to Eureka and recognized it is better for him to be closer to those services. During the move, Sam forgets to take his medication and has a period of not sleeping and ended up at the Humboldt County State-of-the-Art Triage Center in the Mad River Hospital Complex. It's been in operation for many years. From there, he is re-referred to County Behavioral Health and agrees to get services in the older adult program. In this program, he sees a psychiatrist and a nurse on a regular basis, sometimes in his home. He also has a case manager who's familiar in navigating the local medical system and can provide specialized support and referrals to meet Sam's changing needs, including IHSS. He also has a clinician who works with him on his anxiety of growing older. Next slide. So our older adult program is another BHSA, Behavioral Service Act funded program. And this is designed for clients 60 and above with comorbid physical health care and adult protective services involvement or learning concerns. There's some gray in that, but generally it is going to be our folks that are, 60 and above, have, the diagnosis of mental illness. And then there is some fear or some concern that APS might need to get involved with their care unless we really act and help do some preventative work. And so that's really kind of the criteria we look for. They do intensive case management, or older adults case managers have smaller caseloads, on-site and in-person psychiatric appointments. So right now our nurse and doctor will go to the person's home if that's what it's sort of best for the client. They've done that. They go to some of the, they go to some of the assisted living facilities too, and we'll meet folks there as well. And so nursing case management, our nurse there, Deb, is par excellence in that field. And we offer therapy and support. We have a couple of clinician and a half that's kind of assigned to this caseload. So that's who they work with. And as I mentioned, coordination with physical care and APS and IHSS. So the older adults program itself actually sits in the APS IHSS office there on Leader Street. So that's older adults.
Excuse me, so even though he became rich, he would still qualify for that program?
Oh, Sam didn't become rich. This former deputy director.
Oh, Jack. Oh, I see. I see.
Yes.
Sorry, I thought it was Sam.
It was a weird name.
That's even funny.
Manifesting.
Yeah. Okay, next slide. So that's the programs, and I'm happy to take any questions about those programs. Yes.
Okay, that is a really good question, Marguerite. And just wondering, is there any eligibility for older adults that are beyond just having that knowledge and sort of income requirement or?
No, just, usually they're behavioral health clients, and would have medical, Just those couple of requirements of being 60 plus, having that mental illness diagnosis. And then, there are folks who are in a regular adult outpatient program that are 60 plus, have a mental illness, but they're not referred to older adults. The older adults is really for those folks who maybe there's some kind of real tricky comorbid physical health thing, but most of the time it is that were concerned that they're gonna lose their housing or they're going to end up in a hospital or APS is gonna need to take control over things. And so, we kind of look for those more severe cases like. Yes.
When does the innovations funding end the rest? It's coming up, isn't it?
Yeah, this is probably at the end of the year, so.
My question.
Oh, sorry, I stole Vernon's thunder.
Oh, no. That was what else was done. Anyway,
Yeah, so that, the innovation funding, which, you know, Oliver's not here, but I think the rules on that are gonna change a little bit to where I'm not sure how much innovation programming or money we're even getting anymore, but you know, in this sort of initial program outline, you know, for these programs, we had to go to Sacramento. Well, we didn't have to go, but we zoomed to Sacramento and, you know, had to present this innovation program, got the funding. It's very time limited, 5 years. So I would think within a year or so. Having said that, my thought is that BHSA is really focused in on, you know, housing, right? And everything that goes with that, including supports. And so I would imagine that a lot of the work that REST does qualifies already for, you know, that type of the transition, right? So they would just continue doing what they're doing and.
Yeah, and just to kind of echo that on that thought, Jack, yes, you're 100% right that REST would definitely appear to fit within the housing bucket of BHSA. So we are having some very early discussions around how all of that can be restructured to fit within BHSA. But it does seem that in that REST would be a good fit.
Hi, one other thing just to add to that, it's in addition to BHSA, we also have some of these services are now being funded by CalAIM as another funding source. So that funding will get braided. So I just want to put it out that it is not strictly BHSA for some of these services. We do have some other funding sources. We're waiting to see, you know, how things change, of course, going forward. But CalAIM will also offer the full service partnership services to clients. So we do have other funding.
And a lot of our services like CCT, older adults, regional, we're billing Medi-Cal too for the service. So whatever Medi-Cal doesn't cover, then we say.
Does he have other questions? Kelly? No?
I'm not familiar with the presentation, so I don't have a problem. Sorry.
How many clients in the older adults program, Jack, do you know?
There's probably around 50 or so clients in the older adults, some with varying degrees of services, right? So some might be med support only that just see Dr. Sims and Deb. But some of them get full services.
Are they followed into residential places if they have to go to places like Timber Ridge or
Yep.
other kind of?
Yeah, they would be, yeah, as long as they have that for psychiatry and that's, they're asking for Dr. Summers to continue, they would see folks in Timber Ridge.
Is there a limit, people, their capacity?
Yeah, you know, that not a black or white limit, you know, we get referrals to the program and then the nurse and supervisor, Deb and Supervisor Mark will kind of look at the referrals and see, you know, where they could accommodate, you know, a person. If there's a need, they'll try and fit them in, they'll try and get them. So, but they like to keep it around that general area.
Great presentation.
Yeah.
Thank you, yeah.
Yes. Good idea.
But I will admit that I spent some county time, my AI device, pictures together.
So the next one, can we have the kitties?
Oh, I like kitties. I
Is there any questions, online? Anybody? Would you please, Joe, send that PowerPoint out? That's a keeper.
It's a good one.
Thanks. Okay, click out of it. Thank you very much, Jack.
You're welcome. So the other thing I'll say just real quick too, in terms of my purview and programs, right, there's that adult system of care that's with behavioral health, and then there's a couple other programs, APS and IHSS, Public Guardian's Office, and the vet's office. So those are all things that are within adult system here with behavioral health. I think we're gonna do a presentation soon on public guardian programs, so you guys will hear about that. But just kind of the way we work at APS and IHSS, the veterans is also. Adult, you know, sometimes.
Great. Alrighty. Communications is the time when behavioral health board members can share, ask questions, communicate. Oh, I'll start over with Vernon, because I love to start with Vernon. Okay. Then next we'll go to Kelly.
Vernon and I were just talking about the Brave Faces training that Vernon gratefully brought to our community. When was that? The last week in
The 31st and the first.
right, and so, it was I didn't get to participate because I was overwhelmed with the transition in life, but, I heard really great things about it. So it's a training to teach folks with lived experience how to tell their stories in an effective way to help break stigma. And so I know Vernon's really passionate about figuring out how we can do that better on an ongoing basis and I don't know if you want to speak more to what your vision of that would be.
Well, I'm wanting to people with lived experience to tell a story that ends up in a meaningful message. To change the way that people are looked at and talked about with mental illness / homelessness. And I really believe in this implementation out of Reading. I went through it about 10 years ago. And it really changed my life in a lot of ways. The way that I looked at others and the way I looked at myself and my mental illness. But I'm hoping to be able to implement something similar to that here. Just keep it in your thoughts. Hopefully we can move forward from this point forward.
So from my perspective as a NAMI board member, they also have a training that's called Share Your Story with Law Enforcement. So it's specific to CIT, and so it's a requirement of a grant that we hold to fund CIT related stuff. And so I think NAMI would be happy to partner with Vernon and anybody else that's interested in kind of bringing that to our community. And it's part of our CIT trainings locally to have lived experience panels. So that would be a great way for us to funnel people into, sharing their stories there. But there's also other events in the community where that can be effective. So once I have a little more bandwidth, I'll work with Vernon on that. But if anybody else is interested, please chat.
Margaret?
So in thinking about the Recovery Happens event that's happening in September, I've been in touch, I think I've already told you that Brendan and I are gonna share a table to represent the Behavioral Health Board. But I got a hold of Deanna Bay, and she's gonna give us some, county program information. But one thing that struck me too, and, probably I should talk to you too, Danette, a little bit about that, is that at that event, there are always tables from various programs that do substance use disorder services, but really not all services are able to be, have a table. It's, time and space and all that. So I was thinking of asking if it would be a good idea to have the ones that can't table send to either Deanna or to you, Danette, a a blurb about their program and what kind of SUD services they do. So that when people go around and collect things, they really get a more comprehensive picture than just whoever happens to be tabling. So I'd be happy to help head that up, but probably it should be funneled to either D.
We can discuss that at the meeting, at the recovery office meeting.
Yeah, that'd be good.
Thank you.
That's all.
Great idea.
Raphael.
Just, let's see, communications, getting excited for the SUD conference in, Long Beach. That's August 19th through the 21st. And if you haven't already, I would, suggest, registering. And the hotels are still available in the block, but they're going quickly. So if you haven't got your room, I would suggest doing it, soon. Looking forward to it. I think that's it for communication. The rest we can talk about the SUD. Thanks.
Thanks, Bob.
Hi, everybody. Got a stand down coming up here at the end of September. And nation's finest received a CBHI grant for mobile refurbishment. And staff, we have a clinician and two other case manager and a peer support staff with that grant. So that enables us to go up into the nether regions. It's got a Starlink uplink. And so that van is completely capable of doing all kind of telecommunications, telehealth, all that. And it's we're busy establishing routing to go up into these places that have been underserved, not served at all. Now with some way to be able to provide full service to the native population, the veteran population.
And it's,
Add to that a little bit.
yeah,
So CBI is do the Humboldt program. And so far we hired one clinician. And the other two clinicians will hopefully start posting next week. As a peer support and outreach specialist. And the MSU, he's talking about for telehealth. Yeah, Starlink, and it was good for 12 weeks or 12 sessions of clinical counseling.
so is it up and running now?
Well, we have the MSU, we have the clinician, we're just gonna hire the outreach person for support.
Still a few weeks.
And yeah, so the MSU is running, but I mean, our Starlink isn't quite up and running yet, so we're still hopefully in the more than July.
Excellent.
What does MSC stand for?
Mobile service. So big old van, you'll see it driving around, has the finance on it. It's great.
Beautiful. Needs to come to the service fair.
Yeah, and we'll be there, yeah. We'll set it to work.
How long is the grant good for?
That's a 3-year grant.
That's great. Nice.
Awesome. There's the partnership. Sean, you have nothing? You don't want to talk about how we've been interviewing some of the people? Oh. I know, but just in a little update. So of the 5 people that we have to fill the 3 seats that are still, yeah,
We have interviewed 2, the executive committee has interviewed 2 effective each time. We have 3 going to do probably in our job. So if we want recommendation tree.
yes. Thanks. Alex.
Alright, my voice is a bit weak today, so please don't hesitate to interrupt if you need to slow down or be louder. So during a meeting of the Resilient Empowered Youth across the Behavioral Health Committee of our Youth Advocacy Board, some bills came to my attention that may impact adult services in the county. In particular, SB 67, which makes it easier to serve people SB 25, which would include bipolar 1 under the conditions, that would be CARE Act, requirements, so someone can be compelled to engage in care court, bipolar 1. There's also SB 331, which includes chronic alcoholism under the definition of disabled. SB 820, which would have that inmates in prisons may be given antipsychotic medications without consent based on 72-hour psychiatric holds. That also includes text. I think that was that one or the other bills I mentioned, but it would include text saying that people who have been indicted of misdemeanors would also be able to be given medications of that nature without their consent. And then maybe 416, which would exempt ER doctors from liability and permit them to write holds such as with our youth advocacy board was generally not in support of some of these bills because of lived experience, having experienced harm from these sort of shifts towards more carceral treatments to mental health. Many of us on the board, myself included, have been medicated without our consent. I've had personal experience, not myself, but other folks have had personal experience, like interacting with folks in conservatorships. So all that's to say is I'm not an expert in these, but just thinking about how stretched our county resources already are, hearing the talk in this room about the impact of conservatorships. If I'm concerned about the impact of these bills, I'm wondering if there's room for us to discuss further or to recommend that the board of supervisors be.
Joe, did you hear all of the bills that Alex noted? Because if you didn't, I would love for Alex to provide those bill numbers to Sharon and to you so that you can put it in the notes so that Sharon and Nancy can take a look. I wouldn't mind us coming back and speaking about them more if you wanted. I don't know how you agendize things, maybe that's at the, at the exact.
Yeah, we can put it on the agenda, the executive. Future items.
And thank you for looking at all of those, Alex, that's awesome. Thank you.
I'm taking your number.
Sharon.
Oh, Sharon.
Hi, thank you so much. And Alex, that's terrific. Thank you so much for those bill numbers. I recognize a number of them. We are watching them closely. One thing I wanted to offer, and it's at the will of the board, of course, Vernon and I have spoken in the past about an ad hoc committee or some people that are interested in discussing some of these bills. And then the Behavioral Health Board could choose to take a position. And what you are doing essentially is you are choosing a position on a particular bill that you then recommend to the Board of Supervisors that they take this position and why. And and we can assist you with that. Nancy Stark and I can assist you with that process. But if it's the will of the board, we can certainly set up an ad hoc meeting to discuss these bills. Vernon had another bill that I'm blanking on the number, but we can wrap up some of these others and do it as a group and come back or whatever you choose. But we certainly are thankful that you are looking at these bills and love to get your input on them. Thank you.
Thank you. Yes, Vernon.
I'm glad that was ad hoc committee was mentioned. I just got Raphael's information. We will be making for the next executive committee a request to start an ad hoc committee.
Okay, do you still have the form?
I still have it.
Okay, great. That would be wonderful. Do it. Yay. Thank you.
I'll add as well that I'd be in favor of being part of an ad hoc committee to discuss. A couple more things as well, just acknowledging that our new organizers, HSBC, were the ones who brought these bills to my attention, to our dad's attention, and so a group of us keep an eye on them. Also, y'all might be interested in looking at AB 255 about supportive recovery residence programs. It would add text to the bill, revising it before it said that folks may not be evicted from recovery programs for relapse. The text would now read if the were passed, they do prohibit automatic eviction of relapse. So something going.
Thank you.
Thank you.
I know it's not like an item on here for discussion right now, but I do think that ad hoc process sounds really good. And it would be really helpful in future years to do it like pretty, like, it's sort of late in the legislative process right now. And a little bit, I got a little bit of a cool response from some of our legislators staff at like making some comments this week about bills. They're like, it's kind of late for us to amend. So it's just, it was helpful for me to realize that like when it's hard to, you know, because now some of these bills have been amended 2, 3, 4 times. But they're feeling like their chances to amend them are very slim now. So it's hard to kind of find that exact ideal time when it's close to its. They're still willing to receive that input. I just got the feedback that it was late for the things I was asking about. So it does definitely feel like May is sort of the like ideal time to like weigh in if you're seeing changes. So I just thought that was helpful. We passed our budget this week. And let's see what else. Definitely keeping an eye on the budget because yesterday or Tuesday, they reached an agreement on a spending plan for the state budget, I should say. And so some of the implications of that are starting to roll out. I think one of the big ones was like formally the HCAP program, the housing, can you help me with what that stands for?
Housing Assistance Program.
Yeah, okay, that program was like formally not included, but then now it's being included in the trailer bill. So TBD on that, and then there were a number of programs that were where funding was initially proposed to be taken away and then looks like it's been returned for like the home safe housing disability advocacy, a couple other programs, and some behavioral health one-time funding for Prop 36, which is great, but also scary. Because yeah, so there was a lot around that. I'm sure their team are tracking that probably more closely than I am, but it's just interesting to see kind of what that is looking like. That isn't final yet, but it looks like there's a general agreement on that spending plan. So we're closer to knowing what the state funding picture is going to be, which I think is going to be really important. And beyond that, I didn't have a ton to bring today. Yeah, I know it was a big hurdle to get to the point of having a budget for the county that we could pass, that people could live with, and it's not, I know it's not easy right now. So I'm conscious of that and keep showing up.
Ned, do you have communication? No? All I will say is I sent an email out to everybody and need a short little 2-3 sentence bio. Got your photos taken. I'm gonna take yours after. Please, or you can send me one, but for the annual report, we're gonna have our faces to the community, so. Yes. And that's all I have right now. So we'll move on to reports. We have Director Beck with us.
Yeah, thank you.
Thank you.
I would like to mention that Crossroads just celebrated their 50 years and we recognized them at the Board of Supervisors meeting on Tuesday, so that was really wonderful. Thank you, Natalie, for your kind words for them. Wes and his team has just worked really hard recently to just keep up the good work that Crossroads has been doing, so I'm really happy about that. Cause they do get to have a new program in Henderson Center. I think you've all heard about that, but, and maybe you're gonna talk about that a little bit. I don't know. But good work happening there. I'm really pleased with that. We were recently, I was looking for Nancy. I'm not sure if Nancy is on or not, so I'm just gonna speak for her. We talked with Nora from Senator McGuire's office. They're doing last minute, discussions around one-time funding. And, Sorrel Leaf was one that came up, and then also the Mad River Crisis Triage Center, if they were short on funding. So we actually did put a plug in for funding for Mad River and for Sorrel Leaf. Sorrel Leaf contacted, I think Supervisor Bone and also Senator McGuire's office around asking for additional funding. And really, Nora had referred him to Supervisor Bone because the funding has to come through the county for distribution. So that we may get additional dollars there through the budget. As Natalie talked about the state budget, you know, we received the May revised information around the state budget, and it was really off. And really put us all in, made us very nervous about what next steps were gonna be, even because we're already reducing FTEs and our budgets are in a way that we can't really think of decreasing any other services, but so they were really awful. And some of the funding has come back through the state's process. So it makes us be happy that there's like gonna be additional funding, but it's still bad. Like I was talking with Nancy about it this morning, it's still awful because it's still taking away funding from us, but it's better than it was, so that is good news. We'll have a state budget approved and then we'll wait to see what happens with the federal budget. And then I think that the state will then go back into session to do additional changes. Because they'll have to, based on the federal cuts that we may receive. The hardest part for us in DHHS is it's not only DHHS services being impacted, but there's so many other services in the community that are being impacted too, that it's just gonna really hurt our community members. We've built a really nice system. I feel like we've built a really nice system with our partners to provide every service imaginable to all people in our community. And this is really pulling back all sorts of things that we worked so hard to implement. So so much work, and just adding the work requirements, on the federal side, just adding the work requirements back is gonna add so much work to our eligibility and benefit staff. Because right now they're doing annual redeterminations. And now we'll probably have semi-annual. And then all of the income verification stuff it's just gonna be so hard. We're gonna lose a lot of folks through that process, I know. And it'll just, it'll end up impacting our healthcare systems and everything, so. And we're doing everything possible. Staff are really looking at all ways that we can prevent the impacts in the community as much as possible. We've had some very good conversations with our healthcare CEOs about what we can possibly do together to minimize our systems. So I wish I had better news than that. We've talked about Prop 1 before, so we got Prop 1. I can't even say enough how wonderful it is that we got the Prop 1 for sempervirens, but also in our community, there was another, I don't even remember how much, there's like $100 million almost to our community for services. Our tribes got a number of Prop 1 grants in addition to, the 43.5 million that we received for sempervirens. So really wonderful stuff. And that's all.
Okay, thank you.
I'll just plug a few for me and then I have a few for my programs. We're still working on our strategic planning and our racial equity plan, and we're working on aligning those, all of that work together. So that's continuing. We, across the department, we're really focusing our efforts on increasing our direct services percentage. So there's been a lot of work going into that to help improve our budget and cash flow in behavioral health. So we're making progress on that as well to meet our targets. I'm not sure if everybody is aware, but Kaylee Emery, our children's behavioral health director, resigned, and her last day was yesterday. So we're pretty sad about that, but Martin Stepan is stepping in as interim for children's to help out. So that's been good. Having Martin step into that. And also coming into this end of this fiscal year, our contract completions were 100% for behavioral health for this contract go around, which was really good. But it's a huge effort with all of our analysts and programs that are involved in getting those contracts completed on time, especially given that we have them in a new system now in Laserfish. So it's a little bit, the process is different. But our staff did an amazing job there. Also, we have a new patient's rights advocate working for behavioral health. Her name is Carla Plata Torres. So we'd like to give a big thanks to Betty Garfield for filling in for the last year as our patient's rights advocate. So she did an amazing job there. We really appreciate her, and we're looking forward to Carla standing up and taking on that role moving forward. So for my programs, QI has been really busy lately. We've had a lot of, as always, but it seems like now a little bit more so. We've had several audits and surprise visits, one from California Department of Public Health, investigating some allegations on SV. All were unfounded. And also we do have a corrective action plan on that related to our completing of our clinical documentation for staff that are no longer with the county. So we're working on a plan of correction there with CDPH. And we also have a couple other upcoming audits with Department of Healthcare Services. One is SV's site recertification. That's a anticipated review that we have with DHCS, as well as a couple other projects related to our network adequacy and our timely access to services. So we're working with DHCS on a couple of those aspects of the work that we're doing with them. But it's DHCS has really expanded their personnel over the last during the pandemic, and now they're kind of into their roles now. So it's a lot more active engagement with counties. So we're really feeling that now with DHCS. Shifting gears on that, our MIST team is 24/7 since the beginning of the month, so that's been going smoothly. And nothing new to report there. That's been going really well. I'm actually pretty pleased with how things have been operating here with this. Also, we have the SB 43 work group steering committee is still happening monthly. I had to cancel last month's meeting due to that surprise review by CDPH, but we're on track for this coming month's meeting. And the state just released some more information around LPS designated facilities and then some interim regulations related to SB 43. This is kind of the outline of things that current designated facilities would need to do in order to become a SB 43 SUD designated facility.
Oh,
So they're asking for comments on those until next week, I believe. So we're reviewing that, those interim regulations now, and hopefully we'll provide some feedback. But those are really interesting, but raise some interesting questions about what that might look like for facilities like Santa Barbara or Crestwoods, MHRC, for instance. So yeah, that's it. That's it for me.
Would that include like our crisis residential and that kind of placement also, or are we just talking about locked facilities?
Yeah, we're just talking about locked facilities,
Okay.
As a, and this is to capture those folks with severe substance use disorder.
Yeah,
Detainments,
Okay.
for treatment.
that's really, I'm just really happy to hear that there's going to be somewhere for folks to go, because at this point there hasn't been. So if there's a way to, I don't know how the dual, we already treat dual diagnosis, but and this is gonna be so much different. I'm glad they're trying to figure out something.
That's true, and the typical things are that they want in place for these designated facilities are MAT protocols, in place, and what to do with regards to induction and or maintenance or continuance. Those types of policies and procedures need to be in place. So they're also looking at a 18-month window for programs to apply for that designation. That would start January 1st when we implement. So 18 months from there, we wanted to do that for Santa Barbara, for instance, we'd have 18 months to apply for that designation or as we.
You're looking at how, if you have more SUV people and then you have less.
Yeah.
Will help, I mean.
Yeah. Right, and
Crazy.
yes, especially when our current bed utilization for LDS population on Semper Barbara still is hovering on the 60% of bed availability. So it's still, yeah, it would definitely impact, it's gonna impact our system. Sure.
Kelly, may I ask a question?
Of course.
I was curious if you have any stats on call volume for missed and like hours and things like that. I mean, I know you may not have like.
I don't have specifics, but it's been quiet. It's, yeah, just.
Say the Q word.
It's, well, I've been in crisis long enough and I've said that plenty of times and everything's been okay, so I think we're, but that's, now it's gonna get me. Yeah, call volume has been, manageable,
Good.
but, nothing, in fact, it's been lower than traditionally at
I mean,
this
do
time of
people
year.
know it's available?
Well, we're not out, doing public service announcements and getting ad space, on billboards or anything, because we're still understaffed. So the team of 4, including myself, is holding it down. So, yeah.
Are you dispatching through the crisis line? Okay. I'll spread the word for you.
Well, I mean, the important part is that if people are in crisis, you know, there's another option.
Yeah.
On that last matter of being designated for SUD stuff too, is that something that all these kind of agencies have to do, or just if they want to be designated that way?
Right, just if they want to be designated in that way. It's not a requirement for us, but you know, keep in mind, we're in the North State here where there's no other options. You know, around our, in the North State. As far as alternatives, and I think, you know, that's been clear in our work group steering committee, is that, you know, that gap is still there.
Right. And is the county mandated to adopt it at some point
January
regardless?
1st.
Yeah, so if you don't have a place for them to go.
Right. What I'm hearing from the Directors Association work group that I'm in around SB 43, a lot of counties have a very limited number of those designated holds placed.
Kind of. True for us. We're special. Well, I mean, look at the number of conservatees we have compared to other counties. I just.
I do think that there's still a lot of question around severe substance use diagnosis and how long we can hold someone after they're clear. Right, like, what do we do with folks? How do we hold folks that are not experiencing substance use? Right, psychosis at this point, and want to go back to doing their that's where the MAT comes in, I think I think just having that outgoing service available is gonna be really important.
Being able to get into residential treatment directly.
Being able to get into treatment. Yeah.
Area.
What maybe with
Crossroads expanding, or Crossroads, yeah, maybe there will be more residential beds.
There's gonna be a big gap, so.
Well, there'll be a lot of purpose. One thing that we talked about in the SB steering committee or work group is establishing clear protocols to these linkages to handoffs to you know, to Crossroads or to Aegis or, you know, to what we have or to Waterfront. And making sure that everybody's aware of that and knows how we can make those transition for those that it's appropriate for that hit the emergency departments. So that's one thing we had talked about last time in the meeting. So I think a lot of the work is gonna be focused on that in the committee moving forward. So yeah, it'll be good, continuing to have these meetings. Collaborating as a community around how we're gonna approach this to meet the needs of our community.
that just made me think, and don't let me forget about this, Paul, but the opioid settlement funding committee approved some funding for a position that will be designated to assist with that referral to a partnership for that bottleneck that we're experiencing currently, when to get people the services when it's needed. It seems like we have such a delay that it causes people to decide to go about their business instead of getting treatment because there's such a delay. So, I think that could be helpful for SB 43 implementation also to make sure that because that was my main ask, was just making sure that we're doing something around that bottleneck. Right now it's pretty bad. Yeah, that's the biggest complaint that I hear, is people can't get into services with it. Problem.
Huge problem.
Detox especially.
Detox
Yes.
especially.
Thank you.
Got anything, Jack?
I don't think, not too much beyond what I covered. I maybe I mentioned this at the exec board meeting, but we've been talking about it over the years, just our efforts with Cal Poly Humboldt and the intern program there. We're starting to do interviews now for clinicians that have their number, and we're to the rest this last year. It's really grown, this partnership that we have with them, and now we're getting even counseling psych students as well, which never seemed to happen. So we get those on the LCSW track, those on the LMFT track. They're interning with us and then turning around and applying for our jobs. And so a few interviews coming out this week. And
Wonderful.
Yeah, that
it's
is.
been a good deal for us to relationship with them.
It's great. Even though that, part of that program is. I have to move out of my office so that I can take that bed. It's all right for the great. Oh. All right, but I digress. The SUD committee update, Natalie?
So, I pulled it up. So this past meeting, the committee brought up the NO initiative for Humboldt County. And there's a Dr. hope I say it right, DeVito, medical director of partnership, that's planning on doing a presentation on nitrous oxide, which is really exciting. The Board of Supervisors voted unanimously in favor of the bill to ban sales. Details are still being worked out. Anyways, sorry. The international, that's actually here. International Overdose Awareness Day preparation, planning is going, it's August 30th. Tacos donated from Esmeralda's.
August 31st.
August 31st. I was thinking of my birthday. There's a new detox project on East Street coming soon. We're pretty exciting. I'll talk more about that. I wanted to talk a little bit a discussion we had in this meeting. So there's a lot of sober living beds empty right now. And in our meeting, it was kind of discussed that it's because of new life discovery. And so I wanted to share something that I think that a lot of people are being referred to sober livings. And there's a couple of them that charge more than general relief pays for.
Yeah.
And so one of them is actually asking for a $500 deposit. Even though probation or anyway, so and then, people have to pay that back. At some point when they get a job, generally you have to pay back. Anyways, I just want to share that, I did talk to Naila at the county about how we need to let these people know. On both sides, that if you're accepting general relief, people can't work on it. I mean, they can work, but they, can't expect somebody on general relief to pay 500 when they only can have 300 or whatever general relief is. And so it kind of puts people in a bind to get caught up in a wreck. The other thing is, the programs that actually offer food with their, with like New Life, they get 3 meals a day. Well, immediately their food stamps get discontinued. So like, I think it's important that if we work with people.
We are going to pause this meeting right now.